Hello and welcome to the CME Jeopardy program entitled Testing Your Skills in Blood-Based Multi-Cancer Screening. We're honored to have participants from across the country here this evening, not only in this room, but also viewing online. This program is supported by an independent grant from GRAIL. A few important housekeeping notes for those of you in the room. To answer polling questions, please use the keypad provided. Your responses are anonymous and very important to the outcomes of this program. The information being presented is available online. The link is listed on the card in front of you. This card also provides links to valuable clinical resources, educational activities, and patient testimonials. As part of our ongoing efforts to evaluate impact and refine future activities, please complete and return the two-sided evaluation form before you leave. The MCED Roadmap handout is yours to keep. This handy tool can be used to discuss early cancer detection with your patients. For everyone joining us online, the system will prompt you to answer polling questions. The information presented is located on the right side of your screen under the Handouts tab. The evaluation will automatically open in your web browser following the conclusion of the program. For our live audience, please use the question cards located on your table to ask questions. Ushers will be collecting them throughout the program. If you are online, please submit questions through the Q&A box on the right side of your screen. Now, let's give a warm welcome to our presenters. Dr. Mark Gomez, Dr. Gautam Agarwal, Dr. Mylinda Massart. Enjoy the program.
All right. Good evening, everybody, and welcome to a CME Jeopardy event, testing your skills in blood-based multi-cancer screening. My name is Dr. Mark Gomez. I'm a board-certified internal medicine physician practicing out of Naperville, Illinois with Endeavor Health. I'm joined by my colleagues, Dr. Mylinda Massart, Dr. Gautam Agarwal, and we are so excited to be here tonight because it is Thursday night. And we got pom-poms. I love doing this kind of stuff, but I am incredibly honored to share the stage with my colleagues, and we are incredibly humbled to be here to talk to you all. So if you're here for the blood-based multi-cancer screening talk, you are in the right room. And if you're not here for this talk, stay for this talk because I promise you will learn something and we're going to have a great time anyways. And of course, we're going to get to lovely Jeopardy. And I don't know, Team Massart or Team Agarwal, I don't know who's going to win, but you guys are going to contribute. We're going to have just a great time. So thank you again. And last thing I say, there's a football game on tonight, but you know what? This is better than football, isn't it? Continuing medical education for the win. All right, thank you for joining us tonight, and thank you for all of you online joining us as well, too. So we just have a few disclosures, but we're going to get started. All right, everybody, get ready. Grab your ticker. Now, before you do anything, pay attention. If you see that finger in the corner, that means we're telling you something that hopefully you're going to be remembering when it's time to do Jeopardy. All right, pay attention. All right, let's go ahead and advance the slide. All right, the learning objectives of the day. Describe the role of blood-based cancer screening in addressing the limitations of current guideline-recommended screening modalities and improving early cancer detection rates. We'll be explaining the use of methylated cell-free DNA for the early detection of various cancer types and their tissue of origin. We'll be discussing recent clinical trial and real-world data on available and emerging blood-based multi-cancer early detection screening tests. And lastly, it's important to recognize the eligibility criteria for MCED testing and appropriate follow-up pathways should a patient receive a cancer signal detected result. And I will say this, before we answer this question, we are here tonight, many of us primary care physicians. Diagnosing cancer is what we do. We're really good at it, and it's something that we're aligned with in our core values as clinicians. What we're going to be talking about tonight is nothing more than I see as an extension of our core values as primary care physicians, diagnosing cancer early when we can make a difference for outcomes. All right, grab your stuff, everybody. Here we go. Approximately how many patients aged greater than 50 years do you see each week? None, 1 to 10, 11 to 20, 21 to 30, greater than 30, or I do not manage patients aged greater than or equal to 50 years old. I feel the music tonight. You dance a little bit too, a little vibe. All right, let's go to the next question. Whoops, there we go. Question 2. How familiar are you with the currently available blood-based multi-cancer early detection test for adults? Not at all familiar, slightly familiar, moderately familiar, very familiar, or extremely familiar? Go ahead. Number 3, with approximately what percentage of your patients aged greater than or equal to 50 years do you currently discuss the possibility of administering MCED tests? None, 25%, 50%, 75%, all of your patients greater than 50, or I do not manage patients 50 years or older. Next question. Approximately what percentage of American adults are not current on at least one routine cancer screening? Breast, cervical, colorectal, lung, oral, prostate, skin, and testicular. 30%, 55%, 70%, or 87%. Take a stab at it. Let's go to question 5. Many MCED tests utilize methylated cell-free DNA to identify the cancer signal origin, or CSO. Based on a recent meta-analysis, what is the average CSO accuracy of cell-free DNA-based MCED tests? 2.5%, 43%, 79%, or 96%? It's okay to phone a friend too while you're at this. Text your neighbors, talk to your table mates. Let's go to number 6. Based on the MCED screening guidance report published by the MCED Consortium, eligibility criteria for MCED testing include all the following risk factors except hypertension, chronic inflammation, immunosuppression, or obesity. Let's go to the last question. This is a lot of work, right? All right, here we go. Emily is a 51-year-old woman whose older sister died of breast cancer 7 years ago. Emily and her sister tested negative for all known breast cancer-related gene mutations at the time of her sister's initial diagnosis. Despite being up to date on her current mammography screening and recommended annual MRI exams, Emily recently took an MCED test that revealed a signal-detected predicted breast origin. What would be the best next step for Emily at this time? Referral for MRI with contrast, referral for repeat BRCA1, BRCA2 genetic testing, referral for diagnostic mammogram with ultrasound, or lastly, wait for results for Emily's next screening mammogram and MRI. All right, so thank you guys. All right. Well, when we're talking about cancer, we always have to talk about the burdens. And many of us recognize the burdens of cancer. We know that cancer is the second leading cause of death in the United States. We know that 40% of individuals will be diagnosed with cancer in their lifetime. And the interesting thing is that 70% of us are not up to date on at least one routine cancer screening. It is estimated that this year alone, there will be greater than 2 million new cancer cases that will be diagnosed, and greater than 611,000 lives lost to cancer. These numbers are higher than 2023. We have to do more. Now pay attention, by the way, there's a finger up in that corner, so pay attention. But we have to do more when it comes to cancer screening. So why are people behind on routine preventive cancer screenings? Well, there's a myriad of reasons. Whether it's not experiencing symptoms, or no family history of cancer, or even being unaware that they need to be screened. We know about skepticism of the healthcare system. I know from personal experience, my father has prostate cancer, and we have a raging history. I always say in my family, in the Gomez family, we grow colon polyps like how farmers grow vegetables. And so, when I go for my screenings with my primary care physician and my colleagues, I get nervous. We've all been there. Inability to afford the cost of screening. So the reality is that we know that if we adopt early detection and we talk about the benefits of such detection, we can really influence the behaviors of our patients and allow and get them more likely to schedule the routine cancer screening. We also know that more than half of cancer deaths in this country are due to cancers that are ineligible for USPSTF recommended screening. So how I like to think about it is, think of a glacier. We have our single cancer screening paradigm at the top of a glacier, but what is beneath the surface? That's what we're thinking about. Some of these cancers beneath the surface are some of the most aggressive cancers, and we want to find ways to screen for them. As a matter of fact, one recent study suggested that almost 70% of cancer deaths in the US are from cancer types that are not eligible for guideline-based single cancer screening. We have to do more. We do know that when we do more, that the survival is higher when you have localized disease as opposed to metastatic disease. And we see this as incredibly important when we're talking about early detection. No patients ever say, "Doc, I wish you diagnosed my cancer later." It's always, what can we do earlier? We can go back to our core values as clinicians of diagnosing cancer earlier when treatment options exist. Now, we do know that there's disparities, and we're going to get into disparities in a moment, but we have to acknowledge them across cancer screening as well, too. So regardless, across all different cancer types, when cancer is diagnosed earlier, we improve mortality. And conceptually, can we take those cancers that are late stage and move them to an earlier stage? It's up to 13% of stage 4 cancers. If we can move to stage 3, that can result in improved outcomes. If we can reduce it by 13%, we can make a stage shift from stage 4 to stage 3. And we reduce cancer deaths by 21% if we move from a stage 4 to a stage 3, 2, or 1. We see this across all sexes. We see it across all ethnicities, still acknowledging that a disparity does exist, as you can see. So many of us are familiar with the single cancer screening paradigms put out by the USPSTF: breast, cervical, colorectal, lung, and prostate. And note that these guidelines they have been updated. I want to point out the breast that was updated earlier this year in 2024, but many of us were doing screening mammograms in women at age 40, sometimes earlier, but many of us were already doing these kind of guidelines. But remember that the guidelines are always in flux, but we still have to say this, that cancer screening, even what we have on standard guidelines, they do help save lives, make no mistake. If we implement them fully, we can truly save lives. We have to do more, though, because of the cancers that we currently don't have screening for. And it's not that we just don't have screening, it's just that the screening, at least to the USPSTF, has not been robust. We need to find the right tests to look for those cancers. So even though the USPSTF recommends against screening asymptomatic patients for ovarian, pancreatic, testicular, and thyroid cancers, which account to about 11% of all cancer deaths, we just have to find the right way to get there. We know that single cancer screening paradigms truly work and they reduce mortality. We've seen that. As we look at the last decade plus, we see reductions in cancer mortality in breast cancer, colorectal cancer, and lung cancer. So standard guidelines do work. When we think about these guidelines only accounting for 25% of cancer deaths, we have to do more. My colleagues and I here on the stage believe that is through multi-cancer early detection. But before we dive into the science behind MCED testing, let's go back to the disparities because we have to acknowledge that they're real. I'm a man of color. I know there are disparities for me, and there's disparities for people that are in our communities that we see each and every day. Not only are there disparities amongst ethnic minorities and racial minorities, we see it in the uninsured. We see it in individuals who live below the national poverty line. And we even see disparities by education level. We know that when it comes to the risk of death compared with our white patients, we see a higher risk of death in black patients and in indigenous American patients. So there are cancer screening limitations, and we know that even though the single cancer screening paradigms do help save lives, we know that screening tests are not perfect. We have to deal with the relatively common false positive rate. We deal with low positive predictive value that's in the single digits. And we even talk about the burdens of testing or over-testing. But again, we know that the reality is that people are diagnosed with cancers, and us in our lifetime, we're more likely to be diagnosed with a cancer that is not a cancer that we're currently screening for based on single cancer screening paradigms. As a matter of fact, if you're going for cervical cancer screening or colorectal cancer screening or even breast cancer screening, you are multitudes folds higher likely to get a cancer that is not that screening test that you're going for right now. And it's important to acknowledge this reality. When it comes to universal screening or pan-cancer screening, we're going from screening an individual for cancer to screening an individual for cancers. When you adopt an approach like that, the number needed to screen for that single cancer is reduced dramatically versus standard single cancer screening paradigms. And with that lower number needed to screen, we actually can get more prevalence of those cancers. And at the same time, when you have tests that are designed that have high specificity, that true negative rate, we also allow for greater positive predictive value in minimizing false positives. At the end of the day, there's power in the prevalence with specificity and positive predictive value. So there are 4 MCED assays that have received FDA breakthrough device designation, and many of you have heard of some of these. We have OverSee, we have the Gallery test, we have CancerSeek, now known as CancerGuard, and CanScan. And my colleague, Dr. Masser, is going to go through that in a few moments. But it's important to acknowledge what we have, what has received breakthrough device designation at this time. So we look at modeling data. Modeling data demonstrates that the addition of MCED testing to routine cancer screening could result in 3 times as many cancers diagnosed as routine cancer screening alone. And the thing that I like about this is that we can get up to 58% of unscreened cancers that are the leading causes of cancer death. These are the cancers that we want to detect as clinicians, those aggressive cancers. We have to do it. And when we look at the modeling data, this can result in greater than 17% fewer cancer deaths per year. Additionally, modeling data shows that by adding MCED to recommended screening could be more cost-effective when diagnosing cancer in the US. And what we're looking at is when we have a stage shift from late-stage cancers, which are very costly, to earlier stage diagnoses, we were hoping to result in lower cancer screening costs, and the average cost of cancer found is reduced by tens of thousands of dollars. So what I'm going to do now is I'm going to pass this over to my colleague, Dr. Masser, family medicine physician, love it, University of Pittsburgh. Anybody in the house? Pittsburgh. I know. Pom-pom, Steve Masser. Dr. Masser is going to talk about the science behind MCED tests. Dr. Masser?
Thank you. Before I dive into the science behind MCED testing, though, I am going to answer, I think, the question that's really burning on everyone's mind is, am I actually this tall?
Yes.
I am not, but I think this was as close as I was ever going to get to feeling like I'm on an Olympic podium. So, so go yellow. We're going to go for gold tonight. No, the truth is I cannot see over the podium to see the slides, so I am propped quite a bit higher. All right, so now that I hopefully woke you back up, we're going to dive into the science behind these new multi-cancer early detection screening tests. So as we all know, when we do look for cancer and we find something positive on our single organ screening, or someone comes in with a symptom, we often end up going to a traditional tissue biopsy, right? And now this paradigm shift is really thinking about a blood-based biopsy. So how is this different from what we are really familiar with? So blood-based biopsy, literally a single blood draw, which can be point of care right in our clinics, in our offices. It's not as invasive as other traditional biopsies. It can actually characterize across tumor stages just in that one blood draw. It can produce real-time information for diagnosis, prognosis, and treatment of the cancer, and it might even indicate potential treatment responses for that cancer. So when we do that single blood draw, what are we actually looking for in this screening test? So we all know that every cell in our body at some point turns over, and that is the same for tumor cells. And when those cells die and turn over, they release the contents of their cells into our bloodstream. Essentially, all of those contents then get recycled in the body. And so when we're doing that blood draw, we can actually capture lots of those different types of analytes that are being released by those cells into the bloodstream. And the one I really want to draw your attention to tonight is this cell-free DNA, these small little fragments of chopped up DNA that originated either in a healthy cell or in a tumor cell that are now free-floating in the blood. Once we have that blood draw and can look at those fragments of cell-free DNA, specifically the testing technology can analyze the DNA methylation that's happening on these cell-free DNA fragments. So I'm going to take you a little bit back to medical school when you remember studying oncogenesis, which I was actually just teaching this morning to our medical students. That one of the hallmark things that happens as tumors develop is you get methylation changes. And those methylation changes are critical for changing DNA expression, right, to upregulate the types of proteins that are needed to support unregulated cell growth and to down express those genes and proteins that might actually function to suppress or regulate tumor growth. So those are very predictable patterns that happen actually as the tumor is developing. And that blood draw can capture that cell-free DNA, which can then be sequenced for those methylation patterns. And machine learning can recognize those very predictable methylation changes and determine that there is a tumor forming somewhere in the body. In addition to that, I'll take you back to embryogenesis in medical school. You might remember that methylation is also the way that gene expression is altered in our DNA to actually allow a liver cell to become a liver cell, right, and a heart cell to become a heart cell. And so with that sequencing and that AI technology, the machine learning can also recognize that original embryonic pattern to say not only that there's a cancer signal present, but where in the body is that cancer signal coming from, that cancer signal of origin. So now that we talked a little bit about DNA technology, I just want to pause for a second and just really distinguish this type of screening test utilizing DNA technology from some DNA testing that we already might be a little bit more familiar with, right? Which is actually doing familial hereditary DNA cancer predisposition risk testing, right? So things like the BRCA genes and Lynch syndrome. That is a very different type of testing where we're actually asking whether someone inherited a predisposition mutation that makes them at higher risk for developing cancer at some point during their lifetime. Whereas this current technology is a cancer screen, just like our other cancer screening, where we're really asking the question, does this individual have cancer somewhere in their body at this moment in time? So just remembering and recognizing those differences. So I know everyone sees this slide and like their heart falls. Family medicine, I know you're my peeps. We do not love statistics. So I want to go back through and talk about, reviewing some of the statistics that we might use to evaluate these new and emerging technologies to decide, are these really good enough? Do they meet clinical utility and validity and can be utilized with accuracy in taking care of our patients in the clinic? So the first one I want to remind everyone about is sensitivity, right? The test's ability to detect a true positive sample that, you're really catching a patient with a particular cancer, right? So an example of sensitivity, 97% sensitivity would produce 3 false negative results for every 100 samples from patients with cancer. And then we have specificity, the test's ability to detect a true negative So a patient who truly does not have that particular cancer, an example of that is a 97% specificity would result in 3 false positive signals for every 100 sample from patients with no cancer. We also use positive predictive value, which is then the assessment of the utility of the test in clinical practice, measured as the percentage of all patient samples that are true positives. So if that test comes back positive, how many of them are true positives? And then our negative predictive value, which is the percentage of all the negative samples that are true negatives. So these are really important criteria for evaluating these new types of cancer screening. And if we focus first on the specificity and sensitivity, I want to highlight here 5 different multi-cancer early detection technologies that have been developed and have been in multiple different types of trials over the last several years. The criteria, if we're looking at high specificity, the goal of high specificity is to minimize the number of false positives and therefore reduce the unnecessary workup, right? We don't want to chase down a bunch of false positives in our cancer screening of our patients. The high sensitivity is important because we really want to make sure that we're detecting those cancers that we're trying to capture, again, early, hopefully, so that they're more likely to be successfully treated and have a better outcome. So if we apply those evaluations of specificity and sensitivity to these 5 tests under these trials, we can see that there's very high specificity ranging from 97 to up to 99.5%, as well as varying sensitivity. Now the sensitivity is aggregate sensitivity because these are not looking for one cancer in one organ. These are looking at multiple different cancers. And each of those cancers might have their own individual sensitivity. So these are the aggregate sensitivity for that entire screen. The next thing we want to take a look at, as I mentioned before, is that positive predictive value and that negative predictive value. So we want our screening test to have as high a positive predictive value as possible, again, because we want to minimize false positives, right? We don't want to have to chase down a bunch of false positives. And then we want a high negative predictive value because, frankly, I want to sleep at night, right? I want to know that if my patient's test comes back negative, that there's a very high likelihood that they do not actually have cancer at this moment in time. So if we apply these evaluations, again, to these 5 different technologies through these different trials, we see a range of positive predictive value anywhere from 19.4% all the way up to 75%. That's pretty significant when you consider that our gold standard for mammogram, the positive predictive value is 4.4%. And then those negative predictive values are very, very high, again, ranging from 97 all the way up to 99.3%. And then finally, if we are doing this blood test and we do get back a cancer signal detected positive result, we want to know where that cancer is originating from, right? We want to have direction in how to initiate our diagnostic evaluation. We do not want to go and start sending our patients for pan MRIs and pan PET scans. And so we want that cancer signal of origin prediction to be highly, highly accurate. And so again, if you compare again the same studies over the varying different technologies, you can see those high specificities, variable aggregate sensitivities, pretty significantly moderate good positive predictive values, very high negative predictive values, and an accuracy of predicting that cancer signal of origin ranging from 81% all the way up to 91%. So that's pretty accurate. So I don't want to focus too much on this slide today, but I just really want to let you know that there are so many ongoing research studies that are happening both in our country and internationally around these types of technologies. Every several months there's a large National Cancer Society meeting with literally hundreds of new abstracts coming out about this technology. This is just a couple to feature here today, but I really want you to be paying attention because we're going to start seeing more and more of this coming out in our field. So what have we learned so far about cell-free DNA-based multi-cancer early detections? Well, you know, as I mentioned before, the screening mammography, our gold standard, including mammography, low-dose CT scans for lung cancer, pap smears, we tend to have specificities that are pretty good, but not terribly high, and that ends up with low positive predictive values. And that means that we are often working up a lot of false positive patients with these costly, invasive diagnostic evaluations to find that one patient with the true positive. With a meta-analysis of multiple multi-cancer early detections that are now out there being studied, we have an even higher specificity of that 97.8%. That positive predictive value here in that aggregate in this meta-analysis of 96%. And that extremely strong ability to predict cancer signal of origin in the meta study of 79.2%. So overall, cancer at all stages can be identified by analyzing these methylation cell-free DNA fragments with sequencing and machine learning. And again, this emerging technology really has the ability to change and empower us to finally be able to screen for that 70% of cancers that we haven't had the ability to do thus far. So there are many, many more trials that are ongoing. Most of all of the scientific validity studies are completed, and we've really entered into this stage of real-world implementation and utility trials. They're happening both across our country and internationally, and this is just highlighting several of these. And before we move on to our next session, I wanted to discuss a little bit with both of you, kind of your experience. I know all three of us have been early adopters and implementers with this technology. How would you compare multi-cancer early detection and the positive predictive value and negative predictive value compared to what you're used to doing in urology for cancer screening?
Yeah, no, I think, first of all, great presentation. I mean, isn't she so smart? I'm a surgeon, so I don't really understand all that DNA stuff. I just cut stuff out. So, but I'm a urologic oncologist, and so I spent most of my career, doing surgery, and still do, for bladder, prostate, kidney cancers. And in prostate cancer specifically, we have a screening test, PSA, which is, for all it's positive and negative, it's the only thing we have. And what we find is there's a lot of false positives, and unfortunately, with PSA screening, we also catch a lot of cancers that are indolent, and some of the patients that have PSAs that are normal, below 4, still can have a deadly cancer. And so what we need is a test that, like a cell-free DNA-based test, that can detect primarily the more aggressive cancers and not detect the indolent cancers. So, with a positive predictive value of around 20 to 30% for PSA, the multi-cancer model definitely performs well.
Yeah. And what do you think with your experience with, mammograms, low-dose CT scans in primary care?
Yeah, I think in primary care, this is critically important because we've all been there. We've seen those abnormal mammograms come back, and we know that the positive predictive value of mammograms is 4.4%. So we have testing now that can really, when you're sitting there with that person right there in front of your office, you can say, hey, I've got something that's, if it's a 40% positive predictive value that is literally 10 times greater than the positive predictive value for mammograms, this is something that really we need to work on. This is something serious that may be going on right now. So I find it very helpful in managing those cases.
Yeah. And even though it's really exciting and really promising, I do want to re-emphasize that this is not intended to replace any of our current gold standard cancer screening, right? It's really important. Those are in place for a reason. We don't want to miss a single one of those breast cancers or a single one of those lung cancers. This is really an opportunity to complement that and capture those 70% of cancers that are leading to death that until now we just haven't had screening for.
Excellent. Well, thank you, Dr. Masser. Right. So we're going to pass it over to Dr. Agrawal, urologic oncologist extraordinaire. I can throw that in there. There you go. Out of the Mercy Health System in St. Louis. The Lou. All right, Dr. Agrawal.
Appreciate it. I'm usually on the stream team, but now we're on Team Green today. So, everybody, let's try to win Jeopardy later. One thing that led me to really get into precision medicine was in my career in surgery, which I still do. I just did surgery yesterday before I came. What I found was that why can't we find these cancers earlier? I got sick of just kind of doing surgery, and then 6 months later the patient has a recurrence, and it was just kind of devastating and heartbreaking. And what I found was that in precision medicine, where we can kind of have a better risk selection, a better test that can hopefully catch things earlier, and then also not just earlier, but have more accuracy to say we're going to have the right treatment for the right patient at the right time. It's kind of the motto of precision medicine, and led me to want to do better. And so that's something that we all are used to in medicine, is wanting to get better for our patients. And I think this is really exciting. It's better than some of those kind of pizza parties for burnout that we have. We actually get to learn about something so cool that used to be a space age technology when we were in med school that's actually being applied today. So, so considerations for actually using this test. I'm in Mercy Health System, which is one of the largest healthcare systems in the United States. We cover about 4 states in the Midwest, see about 3 million patients a year in our systems, and diagnose about 20,000 cancers. And so, when we thought about forming this program, we looked at multi-cancer detection as our first kind of thing that we wanted to roll out in precision medicine. There's one test that's commercially available. None of them are FDA approved, and there's no established guidelines yet beyond the MCED consortium white paper. So it's ripe for everybody in this audience to really be part of this, so we can write those guidelines and make sure there's equity and access. Patients can access the test on their own, and so it's really important that providers are aware of the test and kind of what to do with it if they end up going through some type of online portal and more like a concierge type situation online rather than in person. Suggested eligibility criteria for MCED screening. So who's eligible? We know one of the #1 risk factors for the development of cancer is age, so age greater than 50. Family or personal history of cancer, if you have some type of hereditary syndrome, genetic mutation, history of childhood cancer. Who's not eligible, at least for the tests that we have in the current marketplace, not tested in pediatric population, anybody below 21. Pregnant patients. Patients who have an active cancer diagnosis should not probably get this test because they are actively having a cancer. That would create really bad signals for the actual test. And people in the last 3 years who are undergoing still surveillance. Risk factors for cancer. I come from St. Louis where, and I was born and raised there, where we have an area where it was a nuclear uranium enrichment site during the Manhattan Project. So if you have patients who are in that area, they probably have a higher risk of cancer, which we've seen, so they would have a risk factor there. Exposure to cancer-causing substances, alcohol, chronic inflammation, immunosuppression, infectious agents we know of, overweight, obesity is one of the big causes of kidney cancer, actually, and tobacco use. So again, just to emphasize what Dr. Massert said, this is meant to complement routine screening approaches to identify cancers that are not covered by routine screening, like kidney, bladder, pancreatic cancers, head and neck cancers. Considerations when discussing MCED with patients, I'll pick a few from these kind of advantages. Really, one of the main advantages is you're screening for multiple cancers at the same time, which we've talked about earlier with Dr. Gomez and Dr. Massert. The other thing is that screening organ sites that don't have a screening modality. So you're not only screening for multiple cancers, but cancers that right now don't have screening available. And really, at the end, when we actually have a chance to make this technology more widespread and adopted and potentially in guidelines, it actually has the ability to potentially reduce disparities because, and I'll talk about that more in some later slides, is that this is a liquid-based test. So it can be done anywhere at anybody's furthest outreach location because it's just a blood test. Disadvantages, big one is it's not covered by most insurances right now. Another one is that there's some potential that you'll have inequity. We just talked about maybe reducing disparities, but until they're widely available, covered by insurance and in the guidelines, there will be some inequity, and that's where we have to do the work to try to make this possible. Accessibility of MCED testing, this slide is a little bit busy, but basically, there's a lot of work being done right now behind the scenes to have patients enrolled in trials, to get the evidence generated so that we can get approvals the Medicare multi-cancer detection screening coverage, Cancer Moonshot Initiative, Vanguard study. Currently there's no consensus guidelines that recommend population-level screening. There's large studies being done in the UK and US that really we need to enroll patients in to figure that out. One thing I'm really proud of is the REACH study that was launched recently, and at Mercy Health we were picked as a site, so definitely if anybody's in the Midwest, send their patients to Mercy to get in the REACH study, but that's opening this fall potentially. What will be cool about this is that it's going to be 50,000 patients, Medicare age beneficiaries, but what was required in this study was that there was 20% participation from underserved communities, whether that's rural communities, racial or ethnic minorities, seniors from historically underserved communities in general. There was a 20% requirement, so that you have to enroll these types of patients, which is amazing. One of the first trials that did that. Something that I'm really proud of is a paper that we presented at a presentation at ASCO, one of the largest cancer meetings last year. And I was able to present about how we implemented multi-cancer detection in our large health system. And what we did was we created a centralized team, myself, 2 other physicians, and then nurse practitioners and other nurses, where we became really kind of experts in this kind of technology and formed the basis where we would be the adjudicators of kind of the test. And so we made it so that it was through our kind of Epic and our data science teams created an online form and provided a referral form where if you as a primary care said, I want my patient to get this, you could have it sent to our centralized team. We would do all the consenting, counseling, talking. So taking it out of the workflow that is very tough, to talk about this kind of test with a patient. So if you found that they were eligible, or if the questionnaire that they did, they would get then sent to our central team. We would talk to them, talk about the risks. We wanted only the highest risk people, of course, to make sure they're eligible, like we talked about in the criteria earlier. The patients were called, they had counseling done, and then the test was ordered if they met those criteria. The sample was taken, the test was sent to the manufacturer, and the results were resulted usually within 2 weeks. What was really cool about this is that if the patient had a negative test, yes, it's great, right? That feels good that you had a negative test. We saw a lot of positive feedback from patients about that. For a positive test, what was also nice is because we had a centralized team, the time from a positive test to the patient knowing about it was within a day. The time to a diagnostic evaluation, for instance, if they had a head and neck cancer signal, we got them in with an ENT and an exam and a fiber optic scope within 3 or 4 days, which is remarkable. They had a cancer diagnosis within 9 days on average in this paper. And they had treatment for their cancer that would have otherwise never been caught within a month. I mean, it's unbelievable. And so really, I felt really proud of the fact that we were changing people's lives, honestly. And we have done now to date about 3,500 tests, and we've had about 25 positive tests that, we can talk about those stories later, but it was truly remarkable, the patients that have had positives that would have otherwise not been diagnosed. And so it was a really cool project, and I'm excited to further that work. So a follow-up for a positive cancer signal test should be individualized. Every positive test is super important. We talked about that. There's the false negative rate is pretty low, and the false positive rate is there, but it's much higher than the true positive rate is higher than most screening. And so a positive test should be taken very seriously. And we're still working on having guideline-based follow-up. But if you look at this next slide, there we go. So if you have a cancer signal, for instance, of breast, pretty obvious. You should probably have them do a diagnostic mammography, a breast exam. If they've had a mammography recently, then an MRI possibly. And this is a published thing, but we also are furthering the work to make sure we have accurate diagnostic evaluation. Head and neck cancer signals seem to come up for us quite a bit. And what's nice is that these are asymptomatic patients. So if they have a head and neck cancer signal, we recommend a physical exam. And sometimes if the physical exam doesn't find something, a fiber optic scope with the ENT and an ultrasound potentially of the neck. And so there's further testing that needs to be done, but I would recommend, definitely with our experience, to exhaust the search for a positive signal. You have experts up here. You can always call us and ask us. But the companies that also make this have their own tumor board type councils where if you have a positive signal and you're not sure what kind of steps to take next, there's a lot of help available to kind of help with that diagnostic journey. So in conclusion, blood-based multi-cancer early detection tests can successfully use methylated cell-free DNA to detect a cancer signal and its point of origin. Modeling studies demonstrate that adding multi-cancer early detection testing to routine asymptomatic cancer screening protocols could result in 3 times as many cancers diagnosed than with routine screening alone, meaning 17% fewer cancer deaths per year. Catching the cancer early is good because then they don't have to have surgery with me to do something really crazy. So significant barriers to incorporation of MCED screening into everyday practice includes lack of guidelines, organizational recommendations, and insurance coverage. MCED tests are intended to complement other screening strategies, not to be used instead of current cancer screening methods.
All right. Well, thank you very much, Dr. Masser, Dr. Agrawal. Thank you very much. Just a quick reminder, there are several resources for everyone here today for more information. So please make sure you grab those handouts and take them with you. And now, what everybody's been waiting for, right? Because we just did the didactic, but now it's about letting loose and doing Jeopardy.
You ready for this?
Yeah.
So we have Team Massert and we have Team Agro. Team Massert's in yellow. Who's at the yellow tables? Who we got? All right. Now we can let it loose a little bit. It's night. I know. We're all good. And then we have Team Agrawal in
let's
green.
Go green. There we are.
All right,
we got
they're already making more noise.
Nice.
Team Yellow.
They are.
And, Team Massert. So we're gonna go over a couple rules. All right. So just like how it's Thursday night football, Thursday night CME here, we have rules of the game. Trash talking is allowed. Did I say that out loud?
Yes, you did.
Yeah.
You're going down, down.
She's actually really short.
So everyone has been assigned to a
She's
team. Dr. Masser and Dr. Agrawal, your team leaders. Dr. Masser will represent Team Yellow, Agrawal as Team Green. Your team leaders will take turns choosing a category and a dollar amount, and both teams will respond to every question using the keypad on your table. The team that answers with the highest percentage of correct answers will win the round. And a coin toss. You guys didn't see it, but it happened. Behind the scenes, happened. Dr. Masser won the coin toss, so she gets to choose first. All right, you ready, everybody?
Ladies first.
We're gonna have a little fun with this. Everybody get a little loose.
All right.
We had some food in ourselves.
Time to wake back up.
It's still nighttime. Yeah, we covered all the stuff.
I heard it's cooling out there. It's like 90 degrees now. So.
I
I know, but we're in the air conditioning.
Better.
Everyone's postprandial, but we're going to be good.
So here are the categories. We have what's the number? Data dives, early advantage, and before and after. So, Dr. Massert, you won the coin toss. Let's go.
I think I'm going to start with what's the number for 200?
All right, what's the number for 200? Here we go. Here's the question.
Get ready.
All right, let's do this.
Get your pads out.
The average 5-year relative survival rate for all cancers is approximately 35%, 51%, 69%, or 80%. Go. Use your teammates. We got everybody at the table. Let's go, team.
Let's go. Okay.
All right. Dr. Masser?
I know. I can see they did amazing.
They got
38% got the correct answer. 69% 5-year overall relative survival rate.
Excellent. All right.
So yeah, while the 5-year survival rate is 3 times higher for cancers detected at a localized stage than for those detected at a distant stage, the overall 5-year survival rate for any malignancy from 2014 to 2022 was 69.2%.
All right. All right, let's keep this going.
All right.
Yes!
Oh,
Go Team
Yellow!
Woo!
Let's go green.
What?
You know, I am.
All right, let's go green. Let's go.
Go on, green. That was.
No, you don't get to,
I'm
no bias.
Yeah.
All right, come on,
bias.
pick it up,
cheer.
guys.
You know.
I
Team
think we
Yellow.
vote for everything, right?
Team Yellow.
Everybody
All right.
votes for all of them, right?
No, I mean,
All right,
Everyone,
let's go.
yeah,
All right.
everyone voted.
That's true. That's true.
Oh, they. Okay,
Okay, let's
no.
do it. Let's do it. We'll catch
Okay,
up.
you
We'll
have
catch
to
up.
vote.
We'll go big this time. Okay.
Dr. Agrawal, the floor is yours.
All right.
Get your team going. What are we choosing?
Let's do data dives for 200.
Data dives for 200. All right, here we go. The specificity of an MCED test is the test's ability to detect a true negative result, a true positive result, a false negative result, or a false positive result, and go.
Everyone vote.
All right,
Vote.
come
vote.
on, guys. Come on.
Vote.
Press the buttons.
Everyone votes.
Talk amongst each other. We got this.
Let's go green.
Everyone votes. Green and yellow votes.
All right.
Ooh. Jeez. 41%.
What did I say about family medicine and
my
statistics?
That's one of those.
These are my
This is
people.
crazy. I've never seen a result like
happened
this. This is unbelievable. This is unbelievable.
All right.
We should take
Dr.
a picture
Agrawal?
of that.
We should get a picture
That's
of
a
that.
cool result.
Dr.
Yeah.
Agrawal, go ahead and take it away.
So the answer was true negative. The specificity of a test is its ability to detect a true negative result. The sensitivity of a test is its ability to detect a true positive. I only know that because the answer is right in front of my eyes. So it's not like I.
All right, let's
Thank
see
you.
who won. Let's see who won. Drum roll.
There we go. Good job,
Green on the
Green.
comeback.
There we
I love
go.
it.
How's
All
that
right.
possible when it was like
right.
actually a neck and neck tie of answers?
I mean, it's like an aggregate of,
Everybody vote. Use your team. Let's do this. Dr. Massert, it's your turn. Team Massert, let's go.
I'm going to go bold. I'm going to go early advantage for 600.
That's a good wager. All right. All right, we got to go for it. Let's go. Here we go. Here's the question. The 5-year relative survival rate is at least blank higher for tumors detected at localized stage than at a distant stage, and go.
All right, come on, yellow, vote, vote, vote,
All right.
vote.
Did you listen to mine
got
more than
this.
theirs? She had the real knowledge, though.
Hey, it's 1-1 right now. We got this.
1-1.
Tie game.
One.
All right.
Wow. Good job. Good job.
Okay.
Very good
Nice,
job.
nice,
Okay,
nice.
excellent.
Okay.
That was way better than the last one.
So Dr. Massert, take it away.
All right, so according to the CDC, the 5-year relative cancer survival rate is 3 times higher for tumors detected at a localized stage than at a distant stage, right? That's the whole idea behind early detection.
All right, let's see who wins. Drum roll.
Yes.
Oh! Oh, man.
I don't know. Come on,
Oh, that
guys.
was some big money there.
That was big.
We got to
money.
make it up.
Big
We got to
money.
make it up.
Now you got to keep up.
I feel small right
It's like,
now.
who's walking around?
I don't know why.
That's big money. That was,
All right,
that
let's
was
do it.
big.
Let's
That's a
do
big
it.
move, Doc.
All right.
Appreciate that. All right. Dr. Agrawal, it is your turn.
We're going big.
Pick a category. What do you got?
Early advantage for 800.
Oh, okay. So
was
this is like some
bold.
trash talk over
Very
here.
bold.
She's going 600.
Bold.
You're going 800.
We got to do it. All right, don't let me down. Don't
Let's
let
do
me
it.
down.
Based on the MCED screening guidance report published by the MCED Consortium, eligibility criteria for MCED testing included all of the following risk factors except hypertension, chronic inflammation, immunosuppression, or obesity. And go.
All right, Team Yellow, come on.
There's some big money
it.
We got
wagers
this.
here.
We
You
got
got it.
this.
This one's hard, but they got it.
You know we're
Easy,
playing with
guys.
Monopoly money, right?
They got it.
everybody?
You guys are paying attention to everything we said, right?
Okay.
Cool.
Okay.
Awesome.
Good job.
Okay. All right. Dr. Agrawal, take it away on the
All
rationale.
right, so according to the MCED Consortium, the following factors known to increase the risk of cancer should be considered. We talked about alcohol, exposure to radiation, tobacco, chronic inflammation, immunosuppression, obesity, but what was not on there was hypertension. So good job, good job.
All right, let's see. Survey says.
Yeah, there we go, we're back.
See?
We went
Green.
big and we
Oh,
won.
this time.
Nice.
Oh, look at the money. Green
Nice.
overtakes
Good job,
yellow.
good job, good
That's some
job.
big
No,
dollars.
come on, Team Yellow. I
that's
believe
some big
in
dollars.
you. I believe in you.
No, all
Come
right,
on,
all right,
and
all
I
right,
got.
all right.
You got
Should we
this.
just end the game
We gotta
now?
go
or-
big.
No,
again.
we are
Okay,
not
all right,
ending the
all right.
game now. Absolutely not.
All right.
Dr. Massert. All right.
You
Where are
went
we
bold.
going on this next one? Please choose.
You know, you went bold. I'm going to go bold. So I'm
Okay.
going to go with before and after for 800.
Bold meets bold. There you go.
Wow.
Big money. All right, here we go. Emily is a 51-year-old woman whose older sister died of breast cancer 7 years ago. Emily and her sister tested negative for all known breast cancer-related gene mutations at the time of her sister's initial diagnosis. Despite being up to date on her current mammography and screening and recommended annual MRI exams, Emily recently took an MCED test that revealed a single detected predicted breast origin. What would be the best step for Emily at this time? Referral for MRI with contrast, referral for repeat BRCA1, BRCA2 genetic testing, referral for a diagnostic mammography with ultrasound, or wait for results from Emily's next screening mammogram and MRI. All right, let's do it. Vote.
Hey, you know this. We do this. Come on. You know this.
We talked about it about an hour and a half ago, I think.
I know. We did talk about it. It was a while ago.
It was a while ago.
I know it was on your slide.
It was on my slide. That's
It was
true.
on your
That's
slide.
Okay, all right.
Good job.
Okay.
That's great.
Very nice.
All right.
Yeah.
Dr. Massart, let's go with the
got it.
rationale, please.
That's right. So it is diagnostic mammography with ultrasound, and if someone had just had that mammogram within the last 3 months, you can go ahead and refer for MRI. So awesome job, everyone. So
Yeah.
come on, Team
All right, now
Yellow.
let's see who wins. Oh man, let's get intense. Look at that dollar value, 1,600.
All right, now we can stop.
Dollar value is huge. All right,
Nope, we're going.
Dr. Agarwal. All right. Team Green's behind a little bit. We going big again? What are we doing? Are we doing conservative, big? What are we doing?
I think that
Gonna go a little
data
easier
died
now?
for 400. Let's just
Okay, moderate.
Let's
Okay,
cool
we'll
off
take
a little bit.
moderate.
Let's cool
All
off.
right.
What happened?
What kind of, this is not Jeopardy.
minute.
What is this?
The Press Your Luck
That's a
whammy?
different
We're doing
game.
Jeopardy? That's two different shows.
Is that like oh my God.
Where
That's
did that
like a
Press
game
Your
that
Luck
my
whammy
parents
come
used
from,
to
though,
watch.
by the way. That's what I'm still scratching my head on.
What
That's
year
the
did that
wrong
game
show.
come
It's
out?
Jeopardy.
I don't know.
I love Press Your Luck.
I've
back
never
in the
heard
day.
of this.
All right.
All right.
Sorry.
Just to be kind,
I know.
I'm gonna keep it. I'm gonna keep it.
All right.
Simple.
I didn't realize family practice. You guys know how to party, man. Jeez.
I got that. All right,
So-
Dr. Massert, what do we got?
Let's do. What's the number for 400?
Okay, that's respectable. Let's do it. All right, here we go. All right. Model data show that adding an MCED to guideline-recommended screening could reduce the approximate cost per cancer found from $89,000 to $3,000, $7,000, $28,000, or $65,000, and vote. Phone a friend, text a friend, sing a song, do a dance, check pom-poms, see what we got. All right. Okay, $7,000.
All right, let's go green. Come on.
Dr. Massert, let's go with the rationale, please.
Yeah. So according to modeling estimates by Hackshaw et al., the projected diagnostic cost per cancer drops from $89,000 with conventional screening to $7,000 with multi-cancer early detection if it's added to the screening paradigm. So that is big.
All right, then. All right, let's see who gets the win. Oh!
There we go.
Okay.
Nice. We're back.
Green.
We're back.
That was a he
back.
stole that. I
Dr.
feel like he
Agarwal's
stole
doing
that.
some subliminal messaging to his team.
All right.
I like it.
Let's get them.
All
Keep the
right.
momentum. All right.
Well, Dr. Agarwal, the floor is yours. Where are we going with next?
Let's stay on the left. What's the number for 600?
All right, that's a healthy wager. Okay. Choose again.
why do I
Okay.
keep on-
Sorry about that. You got the whammy last
Why
time.
do I always
Choose
get
again.
screwed? I don't know what's
That's where we
going
come
on
back
here.
at you, my friend.
right.
Let's do it. Choose another category. Let's do it.
800. What's
Or
the
stay
number?
same.
800.
800.
800.
Okay,
Go
what's the number for 800?
All right. Let's do
All
it.
right, that's what he chooses. What's the number for 800? Let's flip the screen.
All right.
All right,
No
now let's get this
whammies.
question.
No worries.
All right. We could do it for free. All right. The US PSCF recently released the final statement recommending biennial screening mammography for women starting at what age? 40 years, 42 years, 45 years, or 50 years, and go.
All right, Team Yellow, you got this. You know this.
Everybody knows this. We do this every day.
We do this every day.
Every single day.
Yes.
There you go. Nice.
All righty then. All righty then. All right, Dr. Agarwal, give us a rationale for the answer of 40 years.
It's just on the paper there.
I read it on the guideline.
Yeah, exactly. It's in the guidelines.
We were trying to influence the audience when I said, we do this every day. We do it every day. All righty then. Let's see who wins. That's the most important part, right?
To be fair.
Yeah.
There you go. All right.
Reed.
No way.
You know,
We're up. Let's keep it going.
I mean, he's a urologist. He doesn't do it every day. Come on.
That's true. Yeah.
See, I got my crowd over here.
Touche on that one, Dr. Master. Touche.
All right, we're going to get it back, Team Yellow.
All right.
It's getting close. It's almost over.
The floor is yours.
All right, so how about early advantage 400?
Okay, let's see what we got. Whoa! Daily double.
All right, Yellow, let's go.
All righty then.
We
Here's
can
the
do it.
question.
We
Daily
can do
double. All right. You know, how come, you're getting all the fun ones?
Yeah, I get that. Like,
Dr.
I'm just
Agarwal is getting all the
I think you're picking on the
whammies and
urologist.
stuff.
Hence,
I don't know.
Hence the podium.
It's all good.
See
All right,
the
here we
podium?
go. Approximately what percentage of American adults are not current on at least one routine cancer screening, including breast, cervical, colorectal, lung, oral, prostate, skin, and testicular? Is it 30%, 55%, 70%, or 87%? And go.
I don't know if we can cheer for this result.
Yeah, I know. Come on. We all got this, 100%.
Yeah.
84%. Okay.
Yeah, but we can't cheer for that
No,
because
we
we want to do better. We know how hard it is to get our patients to achieve their screening.
Let's go with the rationale. Go ahead, Dr. Massert.
Yeah, so according to the Prevent Cancer Foundation 2024 Early Detection Survey, approximately 70% of Americans are not up to date on at least one routine cancer screening. Cancers included in that survey were breast, cervical, colorectal, lung, oral, prostate, skin, and testicular. Further, more than half of cancer deaths in the U.S. are due to cancers not even included in those USPSTF guideline recommendations. So we need to do better.
All right, everybody in the room wants to know who wins. Let's tabulate. Oh, yellow! Yellow.
All right, it's getting
Man,
close.
Man,
We still have a
dollar gap.
chance.
That is some real
All right, let's
dollars.
go green.
All right. Well,
All right.
Dr. Agarwal, you might have to go big
I know.
on this one.
We'll
But
do
let's
data,
see what you got.
data
What do you got, my
guides for
friend?
600.
What do you got, my
yeah,
friend?
we'll
600? What do you say? What are we doing?
Oh, they want more, but
They want more. They want you to.
He already
data
said
dies.
it.
Okay,
You're
he already
stuck.
said it. Data dies.
Sorry.
He said it. First
We'll
word.
go next
said
next
it.
one.
All
Next
right.
one.
You guys can talk to him afterwards to bet higher next time if you want to. All right. Just go for 800 across everything.
My wife only gave me a
Here
certain
we
amount
go.
of money to.
The goal of the blank initiative is to evaluate the clinical impact of multi-cancer screening in underserved populations, including racial and ethnic minorities, seniors from historically underserved communities, by offering Medicare coverage for MCED testing and follow-up diagnostic services. So what do we have? We have ASCEND, STRIVE, Core HH, or REACH. And go.
You guys know this. I talked about it just 20 minutes ago.
That's cheating.
We're checking that short-term memory. Okay, this should be 100%.
There we go.
All right, 82%.
You listened.
Okay, let's
right.
go into the rationale. Dr. Agarwal, take it away on the rationale
So
why
we
it's
talked
82%.
about part of the REACH initiative. Will provide Medicare coverage for Gallery testing and follow-up diagnostic services for 50,000 Medicare beneficiaries. Definitely is key because it evaluates specifically the underserved communities and typically, racial and ethnic minorities as well as rural areas. So pretty cool study.
Very cool.
All right, let's keep thinking. Who wins? Service says green.
Yeah. See, there we go.
Yeah, you came back.
All right,
big,
bring it
my
home,
friend.
bring it home.
Oh, man. This is
Yeah.
close.
Oh, there we go, 2,400.
Everybody. This is it's so close right now.
Yeah,
I know.
It's
I'm
like,
sweating.
I'm sweating too.
Yeah.
This
I
is
was
crazy.
this close to the aorta yesterday, this close, but this is tougher.
I think
This is
I
crazy.
had an SVT a second ago, something like
This
that.
is scary.
Anyways,
All
it's
right,
tight.
well, I'm going to.
I see you guys. You guys want this.
I mean, Green's getting rowdy, so I'm going to take it down.
That's
a
why I
little
like my
bit.
team. Team Green.
Dr. Master, the floor
I'm
is
going to go
yours.
to early advantage for 200.
Okay, save one. All right.
Oh, yeah.
All right.
What is that? What does that even get
Everybody
you?
gets
What does it even get you?
$200.
I like to mix my games up a little bit.
Everybody gets
parking.
$200. All righty then. So that was a peace offering, I think, between the teams.
You
Everybody
think
got
so?
$200. We're still even. All right, Dr. Agarwal, the floor is yours. Let's go ahead and choose the next category.
All right, before and after for 200.
Okay, you match her 200 with your 200. Okay, that's a nice
I'm
gentleman's
not
offering
a risk
there.
taker, you know.
All right, before and after for 200.
I respect that.
Here we go. John is 45 years old, a non-smoker, has hypertension and a body mass index of 33. John is very concerned about the possibility of having cancer and is up to date on all guideline-recommended screenings. Which of the following characteristics makes John eligible for MCED testing? Age, hypertension, BMI, or John is not a candidate for MCED testing at this time?
Very interesting.
Let's cue the music and vote.
All right, let's go. Come on. This whole table's not even voting. Come on, guys.
Everybody has to cast their vote.
Well, it's your table that's not voting, so you got to get them motivated over
All
there.
right, so BMI. All right, so this is a very interesting case because this is so real to the people that we see, and certainly I can speak as an internist, seeing this kind of a person on a daily basis. But BMI would be the answer on that one. But let me ask this question to my colleagues. When I think about BMI, and we'll see who wins in a moment, but when I think about BMI, I'll ask Dr. Masser, what's your approach on this kind of a patient? What are we doing to mitigate cancer screening risk?
Yeah, I mean, I think honestly, with all of my patients, I always go back to the basics, all the things that we were always taught in family medicine, right? We want to make sure that the patient is up to date on all of their age-appropriate cancer screening guidelines and all their healthcare preventative care guidelines. And then we want to talk about the modifiable lifestyle risks and lifestyle factors that they might be able to make some changes in. And I know that we know that's hard, and we spend a lot of hours doing that kind of motivational interviewing with our patients. But isn't it amazing and rewarding when someone actually does that, right? I just had a patient come back into the office after years and years and years, and I didn't even recognize him when he first walked in the door. He'd lost so much weight, and we had to cut his blood pressure medicine, cut his diabetes medication. And so yeah, I think we just always go back to those basics, make sure all those things that we do every single day are done. But then we now also have, in addition to the USPSTF cancer screening, the opportunity to say there's this brand new technology that's out there. It's available. And you actually said something earlier that kind of struck me. You said it might be hard to have these conversations with patients, but I actually find that the patients get this. They are excited. They've been waiting for this. I mean, how many of you have had patients like me come in and say, hey doc, why isn't there just like a blood test that can test for all cancer, right? They've really been waiting for this, and now it's exciting to finally say, it's here.
Yeah, absolutely. I think it's important, going back to what we were saying earlier, and I love how you said about this is what we do every day.
Yeah.
And so we counsel people across the continuum, we counsel across multiple conditions, and counsel across risk factors for cancer.
Yeah.
All right. Let's see. Do we have a winner on the last question?
All right.
Oh, yeah, you called it. All right, whoever said green.
She
Called
got
it.
it. Good job. Good
I
job.
think it's rigged.
Wow, green
We
is
did it.
edging. Okay. All right, Dr.
All right,
Masser.
Team Yellow, come on.
I thought it was over.
Roll it down
Let's
to
go
What do we
before
got?
and after 600.
Before and after for
is not
600,
up.
big money. All right, let's see what the question is. Jane, a 53-year-old non-smoker, has been in remission from BRCA1 positive breast cancer for 11 years. Jane is current on all routine cancer screening tests. In light of her cancer history, Jane has discussed the possibility of adding MCED testing to her current screening regimens. How often should she repeat MCED testing? Every 6 months, annually, biannually, meaning every 2 years, or Jane is not a candidate for MCED testing, and vote.
I see some good conversations happening out there.
There's only one.
I see some good conversations.
I know, I think people are
flipping their charts back and forth looking for this. Yeah.
It's a tough question.
It's a tough question.
Okay, 67% with annually. All right, let's go into a rationale on that one before we reveal who wins. Let's go to the rationale. Annually.
So there is no rationale.
All right,
and,
clearly.
That's true.
And that's because we don't actually know the answer yet, right? So I think kind of consensus, those of us who are out there doing this think annually makes sense. There's some preliminary scientific data to support that, and more to come from these real-world implementation trials that are happening. But again, I like to think about this and individualize this with my patients and have that shared decision-making conversation. If someone has a lot of risk factors, right, they have that really high pretest probability, we might want to think about doing this more frequently. If someone doesn't have a lot of risk factors, maybe it's just age and nothing else, we might think about spreading it out a little bit more. So again, very similar to our other cancer screening, where we have guidelines, but we're still thinking and individualizing those for each of our patients. So do you guys agree with that?
Yeah. I would agree 100%.
Dr. Agrawal, what's your take, especially with a large system when you guys have implemented this at Mercy?
I think that what Dr. Massard said is very accurate, is that what we're trying to do specifically at Mercy is leverage the ability to understand the risk of pretty much every disease in a patient individually, to say, because of your phenotype, your genotype, your exposome, your exposures, what is your individual risk of, for instance, developing diabetes, your individual risk of developing hypertension, atrial fibrillation, your individual risk of having a heart attack, your individual risk of developing cancer. And if your individual risk of developing cancer, whether it's based upon your germline testing, which is your genetics, your phenotype, your EHR records showing a bunch of variables that is being analyzed by some algorithm that we have, we can say, okay, your risk is very high, so you should probably have more screening. If your risk is very low, then you can have less, like Dr. Massard said. So you'll see over the next few years really a true risk adapted, and finally the promise of honestly individualized and personalized medicine coming to your offices soon. So that's what I'm hoping for.
I think when I've done testing in my practice, you're right, the theme here is personalized, and we have to make it safe, seamless, and personal for our patients that are sitting right in front of us. We've been fortunate, I've been fortunate in my practice to have done quite a good amount of these tests between my partner and I, about 400 tests, but we have to make it to that person. So when we're sitting there counseling that person and talking about cancer risks, we want to make sure it's personalized to what we're doing for them. All right, let's go. Do we have an answer? Oh, wait, so we need to find out who wins. Yellow! Oh my gosh.
Finally.
All right.
Finally, Team Yellow. Woo!
That's what everybody cares about.
Yeah, I know,
more
really.
so,
Well, Team Yellow's going out. Look at
Team
us.
Yellow, I know. We're going out. This is getting really close. This is a nail biter, y'all. All right, Dr. Agrawal.
All right.
We have 2 left. Where are we going with this?
Don't do it.
Before and after for 400.
No.
Before and after for 400. We're taking
the
safe way out, I guess. So here we go.
Good man.
Right,
You are meeting a new patient for an initial visit. His name is Carl. Carl is 47 years old, a non-smoker with type 1 diabetes and a BMI of 24.3. Carl's family history of cancer is limited to his grandmother, who was diagnosed with breast cancer at age 75. Should you suggest MCED testing for Carl? No or yes, and vote.
It's a tough one. That's a tough one.
Thinking it's a nail biter.
It is a nail
This is
biter.
really close. Let's see what we're saying.
It's all about who's buying tonight.
That's true.
It's a good thing that none of us on stage are doing the math on anything of this stuff.
It's even across
All right.
the board.
Okay.
That's tough.
Well, let's talk about this a bit more.
But the no's have it.
So the no's
That's
are
true.
outweighing the yeses. Okay, so let's talk. Dr. Agrawal, since the question, you chose this category, what's your take?
So, it's tough. I mean, in this patient, he's 47, he's not 50, he doesn't have, his BMI is fine. Type 1 diabetes by itself, there's some kind of rare associations, but not really increased risk of anything specific. His grandma had breast cancer at an older age.
Yeah.
So I honestly, if I was seeing this patient, I would probably say don't, it's the value of the MCED test may not help you, right, in this particular patient. So I agree with the audience. The majority picked no. So
Yeah.
Dr. Massey, your take on this one?
Yeah, I agree. I mean, again, it's a very individualized conversation with your patients, and in general, he doesn't have a lot of glaring risk factors. I would again, review the guideline-driven recommendations for health screening for his age, but probably wouldn't strongly recommend MCED at this point in time until after 50, or if something else changed in his environment or history.
I think one thing that's cool about this is as a patient asks you about new technology, it's a great opportunity to tell them about regular screening, regular prevention, like you said.
Yeah, and I actually find that true all the time in my clinic. I tell each of my patients about this at their annual exams, and I actually think it's a great way to get my patients engaged in completing their routine recommended screening, even if they don't choose to do multi-cancer early detection or they're not yet eligible for it. And it really has made a difference just to have the conversation.
Yeah. Last week I had a patient who was coming to see me to have his kidney removed for a large kidney cancer. And in talking to him, so just to show you, surgeons do take histories also. And so I talked to him and I was like, I saw your A1C is almost like 11. And I was like, what is going on here? I can't afford to have a post-op complication and whatnot for him. This guy, so I talked to him, he drinks 10 sugary Mountain Dews a day.
Wow. That's a lot.
That's a lot of Mountain Dews. And the worst part about it, and this probably has nothing to do with MCED testing actually, but it was a funny story. So the worst part is, okay, I'm really not going to do your surgery until you stop drinking the Mountain Dew. We can regroup in a month and see where you're at. The cancer is probably not going to change that much, but your risk will be lower. But he said, what am I going to do for my dog? I'm like, what do you mean your dog? He said, my dog's going to miss, I would share the Mountain Dew with my dog. I was like, that's just abuse. He's abusing his dog. Anyways, let's go on to the last question.
Right.
Sorry.
No, wait. I did.
Okay.
Yes. There you go.
Sorry, I think that's
There you go.
Unless Dr. Massey wanted to say one other thing. Okay, you're just
I
basking
did.
in that green one. Man, this is tied.
Time out. I heard one other really important thing that I think everyone in this room needs to remember. He just admitted that surgeons do histories and physicals.
Sometimes.
And I think we all need to take that back with us.
There you go.
This is a room of primary care folks, so when we get a chance to pick on our surgical colleagues and have fun, that's always good.
Yeah.
Little levity.
Okay.
All right. So
All
it
right,
is tied, y'all.
What's that?
3,200 to 3,200.
I think it's her turn.
This is awesome. All right, it's coming
There's a
down
chance. We have a
I know.
chance.
to the last one. This is Team Massert.
I
they win, it's
need
rigged.
a little Team
It's
Yellow
rigged.
energy.
Right.
Team
Good.
Yellow energy.
Give her some vibes.
Team Yellow energy.
I wonder which number she's going to choose in which category. I don't know. What's
I
like?
think I might take Data Dive for 800.
All right, data drives for
Whammy.
800.
Oh,
Okay,
man.
this
Should've been a
makes
whammy.
it or breaks it, y'all. Focus. We got this. Here we go.
All right.
Many MCED tests utilize methylated cell-free
election was
DNA
rigged.
to identify the cancer signal origin, or CSO. Based on a recent meta-analysis, what is the average CSO accuracy of cell-free DNA-based multi-cancer early detection tests? 2.5%, 43%, 79%, or 96%, and vote. This is close. I don't know what's going to happen.
I'm proud of everybody. I'm proud of the green team mostly, but everybody did a great job.
Half the room's going to be elated, half the room's going to be deflated.
That.
Drinks on Dr. Master tonight, please.
Okay,
this is
okay,
interesting. Very, very interesting.
Oh.
You know what happened here?
Oh.
I see what happened here. The answer is actually 79%.
Correct.
But you know what? One of those slides showed that the aggregate the aggregate positive predictive value was 96%.
But this,
And so I give you points for paying attention to some numbers on those slides. But the cancer signal of origin success in that meta-analysis was 79.2%.
the real answer is what happens? Who won? Who won?
Now I don't know.
No, here we go.
What's happening? What's going
Give
on?
To us.
Come on.
We're not in control of
We're
this.
waiting.
Wow.
I quit.
Whoa.
Wow.
Stage.
That's not even close.
This guy, take him out.
I know. That was close. I mean, kudos to everyone.
believe it.
That was really great. That was great before, we just want to
Everybody
acknowledge
did great.
everybody participated. That was so close.
That was fun.
But,
Good job.
I'd say, Dr. Agarwal, you are at a family practice conference, so there we go. All right, guys. Well, this is such a great game of Jeopardy. We're going to do a couple post-test questions, and then we're going to get into some Q&A. And thank you all for participating and being patient today. It's been awesome energy in the room. All right, here we go. How familiar are you now with the currently available MCED test for adults? Not at all familiar, slightly familiar, moderately familiar, very familiar, or extremely familiar? All right, and the next one here, another post-test question. We just saw the numbers very well. Okay, we like it. All right, let's go to post-test question number 2. All right, with approximately what percentage of your patients age greater than or equal to 50 years old will you now discuss the possibility of administering multi-cancer early detection tests? Is it none, 25%, 50%, 75%, 100%, or I do not manage patients older than age 50? Okay, all right. All right, everybody. That is the post-test questions. Let's get into some Q&A, everybody. All right, so I was handed a whole bunch of questions, so I'm going to read them.
Oh, wow.
Real spread them around. We can all have
We'll
fun.
spread them out,
We'll spread them out. Okay, yeah, let's
Divvy
spread
them
out.
up,
Let's
share
divvy
the
out a
wealth.
little bit.
All right.
Some might be repeats, but that's all right. Many people have the same mindset. We'll go with this first question. And here's the question, and it's a free-for-all up here. But we thank you again for taking your time, spending time with us tonight at an awesome conference and taking time to learn more about MCED testing. Again, as I mentioned, that it doesn't get away from our values as primary care physicians, that we're really good at diagnosing cancer. This is an adjunct that we believe that can be a useful tool for our patients to make everything safe, seamless, and personal. So here we go. I like this question. What age to stop offering testing or screening? I will take that one because we just had a case of a lady who is 81 years old, who is very healthy and has at least a 5-year life expectancy, if not more. So the oldest that I've had right now is an 81-year-old that I've offered this test to because I thought that she's a really good chance of living and fairly well. And so we were happy to sit down, counsel her about this test and go from there. And so, docs, any age cutoff at all?
I agree. I mean, again, I think just like we individualize all screening, right? We all have patients who are young 80-year-olds, and we have patients who are old 62-year-olds. And we have to think about how to contextualize the screening into their lifespan. So I think that's the same applies here as it does everywhere else.
There you go. All right, you want to ask the next question, Dr. Masser?
Yeah, I think this is a really interesting question. This physician says they've been hearing about these types of tests for several years and wonder why are they not yet readily available in our local hospital labs? What is taking so long? And I think that's an outstanding question. You know, I think all of us in medicine know that we feel strongly about evidence-based medicine, and evidence-based medicine takes time. And I do think that we are in an era now where technology is coming out faster and faster, and so we probably are at a stage where we need to change how we think about developing guidelines for how we meet these criteria. And actually, we're going to participate in a panel on that just in a month from now about how do we need to change our guidelines and adapt to our modern day technology and how rapidly it's coming out, so that one, it's getting out to everyone quickly, that it's saving the lives it's intending to save, and that it's also being rolled out in an equitable fashion so that everyone has access to it. So great question, and I hope that we're going to see change around how long it takes to get these things out to our patients very soon in our clinical years.
Excellent. Dr. Agarwal, you want to ask a question?
Yeah,
Or
definitely.
2 more questions?
So, you know, one of the questions they asked was, should a positive test prompt automatic referral to oncology, or should the primary care first do appropriate initial diagnostic workup and general referral once the diagnosis is confirmed? You want, or should I?
Go ahead.
Answer? Okay. So I would say that, you know, at Mercy, at least we set it up so that we have a centralized team. So if a positive test occurs, the centralized team gets the referral, and then we kind of adjudicate the follow-up, basically, alongside with the primary care, as much or as little as they want to be involved with it. So our system's a little bit different, but I would say to answer this for somebody who's doing it on their own, really, if you get a positive signal, you should really partner and explain this test to the people that you're going to be referring it to, because sometimes, as you may know, it's not well known, right? So if a surgeon, for instance, doesn't know about it, then they may say, you know, what is the next step? What am I supposed to do? But what we found is, as we educate people about the test, educate them about what it can predict, then at least all the surgeons that I work with are extremely excited about it. And so forming a team is really important. So when you do have a positive test, you have these people that you already rely on. You guys already have that. You know, as primary care, I'm sure you have a team of people that you always are calling and referring to ask questions to. The other thing you can do is ask the experts. So you can always reach out to one of us. You can reach out to the company that you order the test from to help you with that positive signal, what test to order, and then get the referrals in place. So I think you would use it the same way if you had a positive test for anything that you do in practice, honestly. You have a positive test for Cologuard, or for one of the newer screening tests for colon cancer, that's Guardant or whatever it is, then you're going to have that kind of conversation and make those referrals the way you would normally.
If I might add, Dr. Agarwal, and talk about a real-world case, I can tell you about the most recent positive tests we've had. We've had 5 positive tests in my practice out of 400 tests, and it's a small practice. So how do we do it in kind of the small practice? We had a patient of my partner who was in her early 80s, had a previous history of lymphoma of the neck, diagnosed in 2004. She did chemotherapy at that time. She was about 60-ish years old at that time. She's filed with medical oncology. She has been in remission for basically 20 years. My partner offers her multi-cancer early detection because she has a pretty good life expectancy still, and even in her early 80s. And she comes back with 2 cancer signal origins, the first one being head and neck, and the second one being anus. And so how did we work that up? Well, the first thing we did was, for the head and neck, which is the primary signal, we got the patient involved with our ENT colleagues. Luckily, our ENT colleagues had heard of testing. The only commercially available test was the Gallery test. And they went for a comprehensive ENT exam, including fiber optics, and there was no evidence of cancer seen. The second thing that we did at that time, after ENT said there's no evidence, my partner had her go visit with a colorectal specialist because of the anal signal. as well as suspecting for HPV, saw a gynecologist. The colorectal specialist did a anoscope, found essentially no evidence of an anal cancer. The OBGYN did a pap smear on a woman in her early 80s, no evidence of abnormal cells, negative HPV. She then goes for a PET CT, and the PET CT lights up kind of the upper esophagus, and this is just several weeks ago. We get her into GI. The GI doctor had never heard of the test that's out there, the Galleri test right now. They did an endoscope with an endoscopic ultrasound, and it was found to have a 7-centimeter esophageal mass, which was biopsied, which was staged, which was at least a T3 lesion, and then the patient is now having to choose between an esophagectomy, partial esophagectomy, or chemo RT. So, these can get some pretty complicated stuff. Now, our time for diagnostic resolution to get that cancer was about 100 days. There was a lot of other kind of barriers. The patient lived by herself, needed transportation to go from there. But when you get a positive signal, you got to work it up.
Yeah.
That's basically what it is. And so we see real cases, and it's involving the community to go from there. Dr. Massey, you want to read one more question?
Yeah, I think this is a great question because it's one that comes up a lot, and it says these tests are not currently FDA approved, so can we still order them? And so most of the tests that are currently in development do have FDA breakthrough device designation. And I believe almost all of them are applying for full FDA approval. But what's actually the interesting part is that historically, DNA lab-developed testing actually didn't fall under the FDA purview. And so even those BRCA tests that we order, those Lynch syndrome, all those hereditary cancer tests we order are not FDA-approved tests. Now, just this spring, that has started to change, and the FDA is going to start supervising those. But currently, these do not actually require full FDA approval for us to be able to order.
Excellent. Dr. Agarwal, you want to read another question? We've got a few more moments here.
All right, let's see.
Be mindful of everybody's time tonight.
All right, if a patient, this is a good one actually, all of them are good, but if a patient is not willing to do regular guideline screening, is MCED acceptable for use instead of no screening at all? That's a tough question. I think that if a patient's, it's interesting, if a patient's not willing to do guideline screening, but would they even be willing to do MCED, right? So the good thing is if you had that conversation with the patient and the patient says, hey, I don't want to do a colonoscopy, I don't want to do these things, I want to do this, I think you have to open the conversation with the patient to say, no, you should do all the screening if possible, right? Because this augments that. It doesn't replace that at all, but I don't think it would be wrong to do it, but you have to explain to them that this is not going to be able to catch some of the cancers that, for instance, are at stage 1 that are found with mammography or with colonoscopy finding something like that, or prostate or lung. So I think that you have to really explain to them what this test does and what it's kind of get into a little bit of the statistics with them to say you still have to do regular screening.
Right. I'm going to ask this question. We'll do maybe one more here and then one for Dr. Masser. But here's a question. This is actually for me, so that's why I'm asking the question. It is, for positive tests, do you have any helpful ICD-10s that would help get the next test covered? And I'll have to say, with our 5 tests that we've seen, our 5 positives that we've seen in the practice, so far we've not had any insurance pushback. I think some of the codes I used, I'm thinking this recent case I just described, I'd have to ask my partner what code he ended up using for that one. But I had a case of an individual that was positive for a bladder urinary tract, bladder urinary signal, and I probably put, sometimes you could type in the field, free type. It might be cancer screening. I might have free typed over that said abnormal cancer screening test. Yeah. And so, but there's a host of people that can help fight for referrals or fight for authorizations, writing letters, And this is where it really takes a community of people that have gone through the process, like many of us up here, but also people that can help you out with the testing to find the right way so your patients aren't getting hit with excessive coverages or denials. It's a good question. Dr. Masser?
Yeah, I think this might be a good question for us to end on tonight. This question asks, have any of us actually taken the Gallery test? And so I will share that I am 52 and I had melanoma in 2018, so I actually just had my second annual Gallery screen and thankfully negative.
And I will say I've taken the Gallery test 3 times. And I was the first to do it. Actually, when we had found out about it with my partner, we did the test on each other. Why not? So now now my dad has prostate cancer. So that was my why. I'm not 50, I'm only 46. But I said I had to go. I had maybe a little bit of a lower pretest probability, but I did the test 3 times now, and I'm going to keep doing it annually. That's my plan. Then I'm on with the discussion with my physician.
I'm much younger than both of these.
Yeah.
Says the urologist.
I haven't done it yet, but I've encouraged my parents as well as my brother, who's older than me, to do the test, and I would recommend it in anybody I liked, like my friends and family, just because I do think, eventually, so I will do it in myself, but
okay, you're done.
Yeah, that's all.
Well, everybody,
I'm older.
On behalf of Dr. Masser, Dr. Agrawal, we thank you so much for your participation this evening. Please remember to complete the evaluation. Have a great night. We're hanging out for some questions if you have any questions. And thank you again. Be well, everybody online. Be well, too. Have a great day. Have a great rest of the conference.
All right.
Thank you.
It's good stuff. Good job.
Shutterstock